So I'm going to be talking over the next 20 to 25 minutes on how to integrate scientific evidence into best clinical practice. And I want to start off by thanking all of you for taking time out from what I know is a busy schedule to listen to this important discussion of how to use scientific evidence in how you treat patients. So we'll start off with a few slides just to give you a background on evidence-based practice and its importance. So what happened before evidence-based practice, which we'll abbreviate EBP? Health professionals relied on the advice of more experienced colleagues, often taken at face value, their instinct, and what they were taught as students. We may wonder why the practice of bloodletting persisted for so long, especially when research in the 16th and 17th centuries exposed to significant errors. It continued to be based on tradition teaching rather than evidence-based research. What will physicians think of our current medical practice 100 years from now? They may be astonished at our overuse of antibiotics or the way we reprocess ultrasound probes between patients. Experience is subject to flaws of bias, and what we learn as students can quickly become outdated. Relying on older, more knowledgeable colleagues as a sole information source can provide dated, biased, and incorrect information. It's not to say clinical experience is not important. In fact, it is a crucial part of the definition of evidence-based practice. However, rather than relying on clinical experience in decision-making, health professionals need to use clinical experience together with other types of evidence-based information. And I should say this concept of using evidence-based medicine in the practice of medicine is widely accepted worldwide by governments and by authoritative medical societies as they write their guidelines. On the next slide, now we're going to have a poll of how you use evidence. So please, we'll have about 25 seconds. Please check off all of those that apply for best research evidence playing a critical role in effectively changing clinical practice based on reviewing. 1 research paper, 2 research papers, 3 research papers, or 4 or more. So once this is done, we'll see how you voted, and then we'll have some brief discussion. So I can see that most of you wanted 4 or more research papers. So in fact, I think the minimum you need is 2 research papers. What makes science different is ideally we should always have, in addition to 1 study that demonstrates a specific outcome, a second study done by independent, different scientists coming to the same conclusion. So at a minimum, we always need 2 well-done research subjects. And in many governments and groups such as the Food and Drug Administration in the US require a minimum of 2 papers. Of course, in this case, more is generally better because if you have multiple research studies, then you could do a meta-analysis. And even if each one individually is too small, you could come out to a conclusion. But again, no matter how many research papers they are, if they are of poor quality, they cannot be used to lead to sound decision-making. So why is evidence-based practice important? It's important because it aims to provide the most effective care that is available and ultimately to improve patient outcomes. EBP promotes an attitude of inquiry in health professionals and starts us thinking about, why am I doing it this way? Is there evidence that can guide me? As healthcare professionals, part of providing professional services is ensuring that a practice is informed by the best available evidence, and EBP plays an important role in doing that. You can see on the triangle on the right that at the bottom are just expert opinion, and when you have no data, that's the best you can do. But then we have a hierarchy of research designs, case series and case control studies, cohort studies, randomized clinical trials, and ideally guidelines are based on good laboratory evidence, if that's important, and cohort and randomized clinical trials. And then when we have those, that ultimately gets put into synopsis and guidelines and systematic reviews where the entire research is summarized. Now we're going to turn a little bit and talk about healthcare-associated infections. And I should say, by the way, in the United States, it's estimated that 5 to 10% of all hospitalized patients experience an HAI each year. This results in substantial morbidity and mortality. And in fact, not on the slide, is that in the United States, healthcare-associated infections are the 6th leading cause of death in the United States. In Australia, it's estimated that there are 200 HAIs each year. And evidence-based systems can be used to prevent and control HAIs, And our goal here in this talk is to discuss evidence-based practice in reducing ultrasound probe cross-infection, that is, infection that would be transmitted because a probe was not properly disinfected from one patient to another. Examples of serious HAIs include bloodstream infections. There are 4,000 episodes in Australia, ICUs each year. Mortality is in the 5 to 20% range, costs us more than $35 million. Prevention of HAI is a top priority globally for different departments of health, and HAIs are the focus of multiple national and state reporting requirements and prevention initiatives, as they should be. So let's focus now on reducing ultrasound probe cross-infection, and they can aid in reducing HAIs. It's estimated that for all HAIs, up to 70% are preventable just using existing infection prevention practices. Why do we see transmission related to devices? Inadequately cleaning the device, that is, removing proteinaceous material, improper selection and use of a disinfecting agent. So cleaning must always precede disinfection or sterilization. But if you take an agent that doesn't cover the pathogens, or you use it improperly, wrong dose or wrong duration, then you may not eliminate the problem, the pathogens, and failure to follow recommended cleaning and disinfection procedures, most importantly of the manufacturer of the device, but generalized guidelines as well. Reducing ultrasound probe cross-infection risk can aid, again, in reducing HAIs. Patients are 40% roughly more likely to have a positive bacterial culture 30 days after a transvaginal scan where the probes were low-level disinfected, and 20% more likely to be prescribed antibiotics. This being a surrogate measure of pathogens being on the probe and, in fact, the patient becoming infected. And you can see HR, which stands for hazard ratio of 1.26. MHRA alert released due to patient death from a hepatitis B infection attributed to improperly reprocessed transesophageal echocardiographic probes. So again, these result in more than just infections. These can actually result in death. Now, more than 80% of probe handles, that is not the probe that's actually inserted into the body, but where the user is holding it, are not disinfected, have residual pathogens. And again, that's not surprising. That is when handles and moves the probe, that you would carry the area that touched the mucous membrane of the patient and carry those pathogens onto the handle. And it goes without saying that the colon, the esophagus, the vagina are not sterile and, in fact, have logs of organisms present normally. Now, one certainly should use and can use condoms over the probe, but up to 10% of condoms and barrier sheaths leak. Therefore, their use does not replace the need for high-level disinfection. So I want to repeat that. The use of a condom sheath or barrier does not eliminate the need for high-level disinfection because those are not perfect protection. 13% of probes are contaminated with pathogenic bacteria following routine disinfection, low-level disinfection. I'm not going to go through all of this. The point of having this slide is to show you for transesophageal ultrasound probes, there are many, many outbreaks, and this is not even a full list of all the outbreaks, but just some examples. In Belgium, 42 patients colonized or infected. Mortality rate among infected patients was 40%. An increased incidence of Enterobacter cloacae in a cardiovascular unit was determined to be due to contaminated and poorly disinfected ultrasound probes. Again, a Serratia marcescens pulmonary infections, and again, a cardiothoracic ICU, again, due to problems with disinfection of transesophageal ultrasound probes. Again, this is all because of improper cleaning and improper disinfection. Now we have, again, a similar list of outbreaks, and this time related to rectal ultrasound probes. Again, the first one, again, I'm not going to read them all. Most of those have been attributed to using non-sterile and contaminated gel or biopsy equipment, but not all. One patient was infected by HCV and was compensated by the hospital. There's a case of possible HIV transmission related to a transrectal ultrasound probe. Infections due to rapidly growing mycobacteria related to ultrasound-directed prostate biopsy. And then at the bottom, a Burkholderia cepacia infection of prostate caused by inoculation of contaminated ultrasound gel. So again, improper use of gels, improper cleaning, improper disinfection, leading to transmission. So now let's turn to vaginal ultrasound probe contamination. Again, we're going to have a very nice set of slides later on about HPV, but Hong Kong, 7.5% of probes were contaminated despite a probe cover and low-level disinfection. In France, again, 3% roughly were HIV positive after disinfection, including high-risk HPV types. These are the HPV types that are highly associated with cancer. Again, in France, you can see a substantial number positive for HPV, in this case 7%, and Staph aureus. Similar data from Spain, about 5% HPV positive, and again, more data from France. And you can see, well, the studies differ a little bit, as we talked about, and you agreed with, number of studies. Look at the consistency here of finding HPV. All the studies are sort of in the 2 to 10% range, again, despite probe covers and low-level disinfection. So when you see this happening in multiple studies worldwide, you have to believe there's a problem and one that can and should be corrected. So infection risk was low-level disinfection of endocavity probes. This was a computer model, and I was involved in this study. And the goal was to assess the risk for transmission of infection via endorectal or vaginal ultrasound probes, again, with a probe cover and low-level disinfection in France, used a sophisticated epidemiologic methods, stochastic Monte Carlo simulation. And based on this, and knowing the data I just showed you to inform this, it was estimated that in France there would be 40 new HIV infections caused by inadequately disinfected probes, and then other viral infections, including hepatitis B and C and herpes simplex virus, and of course HPV as well, somewhere between 1,500 and 15,000 people infected. Clearly something that is of major public health importance and should be prevented. The conclusion is to adhere to guidelines such as those by the U.S. Centers for Disease Control and many other groups that we'll talk about to properly clean and then high-level disinfect all endocavity probes. Now, one of the reasons for using high-level disinfection is shown on this slide. That is, high-level disinfection will inactivate all microbes with the exception of high numbers of spores. A few spores may remain, but it will kill mycobacteria, importantly non-enveloped viruses such as norovirus, HPV, fungi, bacteria such as MRSA, Acinetobacter, enteric organisms such as E. coli that would be in the vagina or in the rectum, and of course enveloped viruses. Low-level disinfection will not reliably inactivate mycobacteria or viruses. So how do we decide what type of disinfection is required for different devices and surgery? This is based on the Spalding classification, which is decades old now, been revised, but still is critically useful. So it divides the type of disinfection sterilization is based on the use of the device. So for a non-critical device, that's something that touches intact skin like a stethoscope, low-level disinfection. For something that's semi-critical, that would touch a mucous membrane or non-intact skin, they get high-level disinfection. And for something that's critical, that enters body tissue, then that's sterilization. Now, low-level disinfection will kill most vegetative bacteria and some fungi, but will not kill mycobacteria or spores or non-enveloped viruses. Intermediate disinfection will be between that and high-level disinfection. Again, high-level disinfection will eliminate everything except very high numbers of spores, may not eliminate all the spores. Sterilization means that all viable microorganisms have been destroyed. So again, this is the basis that's widely accepted worldwide, including in the U.S. by the Centers for Disease Control, that determines how we disinfect an object. And again, you can see here just the same thing showed differently. Non-critical, a probe contacting intact skin, and semi-critical probe contacts non-intact skin, but may have, but could also contact mucous membranes or non-intact skin, and then critical would be something that's entering body tissue, like you're doing an ultrasound of the liver during surgery. Now, there have been many publications that provide guidance, and those guidance documents state that ultrasound probes should receive high-level disinfection, that is endocavity probes. I'm not going to list all the countries, but importantly, you see the U.S. CDC guideline, you see Australia, their guidelines from 2017, and many countries worldwide. So now we're going to talk about using that research evidence and that background in the design of drugs and vaccines. So is all published research of good quality? And the answer is no. So just because something's published doesn't mean that the study was done properly. The first thing you want to look at is the type of study, and generally randomized controlled trials give you the studies that are least susceptible to bias, and case series and case reports are the most susceptible to bias. But a good, properly done cohort study may give you better evidence than a poorly done randomized controlled trial. So what are the issues? Validity, meaning accuracy. Can you in fact trust it? Did they in fact use proper scientific and epidemiologic and statistical methods? Impact. Are the results clinically important? And applicability. Do they answer a question that's relevant to you? And the EBP hierarchy ranks study types, design on the rigor, strength and precision of their research methods, and how well the studies were done. And there are much more complicated ways of grading the evidence that are used when setting guidelines in much of the world. Well, let's turn now to the hierarchy of clinical research designs, as we already described. At the bottom is expert opinion, then case control series, case series, which are just just a series of patients with a particular disease or outcome, very subject to bias, cohort studies where you follow patients over time, ultimately randomized trials. And then one can group these studies to make your life and my life easier in ways of giving you a systematic review in which you look at all the evidence that's published in the literature and carefully grade the quality. One of the tools there is meta-analysis, where you combine the data on different studies to come out with the best quantitative answer. Well, let's now talk about assessing scientific evidence for disinfectants and disinfecting devices. Well, first, the demonstration that the disinfectant device inactivates microbes inoculated onto the surface of a medical device. So that's the first thing you do. You take your device and you inoculate microbes on. Generally, you want to use the microbes that are relevant to that site in the body: esophagus, vagina, throat, skin, etc. And you want to put them generally on the device in higher numbers than you would find naturally. And then you look at the disinfectant or the device, its spectrum, that is what microbes it kills, and ideally it should kill all the clinically important pathogens. Speed is important, obviously. In a busy clinic, you would rather have your device cleaned in a minute or two rather than 10 minutes or 2 or 3 or 4 hours. And log inactivation, that is, again, you want to make sure that you're inactivating at least 1 or 2 logs more than you would ever find on the device naturally. Then the next step is that you want to go and look at devices in actual use as they've come out of a rectum, a vagina, esophagus, and see if your disinfection method, a device or a chemical, actually works on those devices and doesn't damage them in any way. And demonstration that the device they use will reduce healthcare-associated infections. This may require a clinical trial, but in many cases, because the risk of infection on an individual patient is so low, although it may be very high on a population basis, you may not be able to do such a clinical trial within a reasonable time or money, in which case modeling can be used to provide evidence of effectiveness, as we showed earlier, the model of the risk of infection with low-level disinfection in France. So what are the properties here of that we're aiming for with our ideal disinfection or device? Broad spectrum, kills all the relevant pathogens, fast-acting, non-toxic, meaning it should be safe for use by the user, to visitors in the area, to patients, should not induce allergic symptoms, and chemicals, if they're left on device, if they're not washed off, can be harmful. Certainly, we would like them to be safe for the environment. They need to not damage the device. They should be ideally very easy and simple to use by the staff. There should be a means to validate proper disinfection. For chemicals, you need to look at time and concentration, for instance. No odor. If there's an odor present, it's acceptable. And then ideally, they should be economic. That is both compared to other methods and certainly economic compared to the outcome we're trying to prevent. So we're going to turn to two devices that are used for high-level disinfection of endocavity probes. One uses ultraviolet light. It's chemical-free. The other is a hydrogen peroxide mist device that uses 35% hydrogen peroxide. But we're going to focus first on ultraviolet light. So this device here delivers ultraviolet C light, which is defined as, in this case, 254 nanometers. It's a specific wavelength. As particles and waves, it's reflected from the chamber walls and ensures there's no shadowing. One of the problems for room ultraviolet devices is if you want to disinfect the back of something, the light has to bounce off the wall. That's not very efficient, but when you make a small device for a probe, you can use mirrors and essentially you have full power at every surface on the device. Ultraviolet light energy penetrates cell walls of microorganisms absorbed by DNA, RNA, and proteins, leaving them unable to perform cellular functions and destroying them. Ultraviolet light is widely used in healthcare for disinfection of water, such as Legionella, disinfection of air, such as in isolation rooms with airborne organisms such as TB, disinfection of surfaces, disinfection of hearing aids, and I should say it's also used in food preparation for disinfecting cutting boards in those areas. I'm going to start showing you some studies here to assess the effectiveness of UVC light to disinfect ultrasound anesthesia probes. 15 probes exposed to non-sterile ultrasound gel infused with large inoculum containing relevant pathogens. The gel was left on the probes for 5 to 7 minutes, then it was wiped off. Probes were wiped with a disinfecting impregnated paper and placed in a UV chamber. So here they were intentionally contaminated with very large numbers of pathogenic bacteria and exposed only for a minute and a half. After exposure to inoculated gel, all probes were contaminated after the gel, but after UV light, all the probes were disinfected with less than 10 colony-forming units. Need to review research references used in research for bias. We talked about that. This was a recent guideline, and what they tried to do in this guideline was extrapolate from the very robust literature of UV disinfection devices in rooms to UV disinfection devices for probes. And I said they're not relevant. It's not a fair comparison. In rooms, don't forget, energy from UV light falls off the square of the distance. So you may be trying to disinfect things that are 2, 3, 4 meters away and may not be in direct line of the UV. Whereas when you put a probe into one of these UV disinfection devices, you're millimeters to centimeters away, and there is really no shadowing. And the energy level, of course, is much higher because the distances are much closer. So has the correct methodology been used? For example, in the Munster article, the study described in this article is clearly invalidated from a scientific viewpoint. While all studies done in disinfection systems, notably ultrasound probes, are done with quantitative microbiologic assays, to discuss studies used a qualitative model, often used in pharmaceutical research, but invalid for semi-critical medical devices. The discussed study finds more contamination after disinfection than before disinfection, which is really not possible. This alone shows the study design was inappropriate and did not have scientific value. In some cases in our study, bacteria found in the second swab taken after disinfection, which we not found in the first swab. So there's no value to this study. There is something improper about that. They somehow are contaminating the devices while they're sampling them, since you should not and cannot be finding more pathogens after disinfection than before disinfection. So this study is fatally flawed and should not be used in guidelines or in critical decision making.